And next we have a discussion on glaucoma. I invite Dr. SANDHYA.
Good morning all. We'll deal with how to present a case of glaucoma. We'll first go to the history. As you all know, primary open-angle glaucoma is always asymptomatic, and primary narrow-angle glaucoma can have history of subacute attacks, which you should ask in the history, which may have subtle pain and colored halos, most probably during the evening time. Then secondary glaucomas, especially if it is unilateral, if the glaucoma is unilateral, you have to ask for a history of trauma, steroid use or uveitis. Now, on examination, I think you can see the difference. That is, here you can see in the this side, you can see deepening of the upper sulcus. So, what is this? This is basically prostaglandin associated periorbitopathy syndrome. And these are the features of this. So, always you have to look for these features. Then you have to look for some port wine stain or something over the face. The most common condition is Sturge-Weber syndrome. And these are other syndromes where you can get port wine stain and glaucomas. Then nevus of Otter is another important condition where you get this melanosis over one side of the face, and these are associated with increased risk of uveal melanoma and glaucoma. On anterior segment, you will have to look for this conjunctival hyperemia, which can occur as a part of chronic drug use, and also dilated episcleral vessels, which can be seen in elevated episcleral venous pressure. These are the causes of elevated episcleral venous pressure. And then you have to look for drug-induced conjunctival and corneal changes. Out of them, the most important ones are reticular epithelial corneal edema caused by Rho kinase inhibitors, then recurrent herpes simplex keratitis, which is caused by PGA analogs, and also conjunctival hyperemia, which is more with PGA analogs, alpha agonists, and also Rho kinase inhibitors. So this is an example of corneal edema, that is reticular epithelial corneal edema caused by Rho kinase inhibitors, and it is more with netarsudil. Now, in anterior segment, what is this? This is correctopia and also polychoria. What is the differential diagnosis? You can have IC syndrome if it is unilateral, and if it is bilateral, you have to think of Axenfeld-Rieger anomaly. In IC syndrome, especially essential iris atrophy, you also have peripheral anterior synechiae in gonioscopy, and in Axenfeld-Rieger, you have prominent Schwalbe's line, which is called as embryotoxon, posterior embryotoxon, and also prominent iris process in gonioscopy. Then the second component of this ICE syndrome is Chandler syndrome, which can cause predominant corneal edema. And important differential diagnosis is Fuchs endothelial dystrophy and also posterior polymorphous corneal dystrophy. So both this Chandler syndrome and posterior polymorphous dystrophy can cause glaucoma. How to differentiate? The Descemet's membrane will be normal in Chandler syndrome, whereas it will be affected in PPCT. Then again in Fuchs, there won't be any associated glaucoma. Another third component of this ICA syndrome is Cogan-Rees anomaly. This is Cogan-Rees anomaly where you can get multiple iris pigmented nodules, and important differential diagnosis is iris melanoma. Then you have to look for pupillary rough. So you look for any loss of pupillary rough, which may occur as part of aging, but it is an early feature of pseudoexfoliative glaucoma. Then also you have to look for neovascularization of iris. Then what is this? Here you can see pseudoexfoliation over the pupillary border. Along with that, you get pseudoexfoliated membrane over the anterior lens capsule. Associated with that, you have peripupillary iris atrophy, and in gonioscopy, you get Sampulaceae line and patchy pigmentation of trabecular meshwork. Then again, you can get Krukenberg spindle. Along with that, you have concave iris configuration that is usually seen in pigment dispersion glaucoma. And along with that, you can get Shee's line or Zent-Meyer's line. And the iris atrophy is different. It is mid-peripheral iris atrophy, and you can get homogeneous pigmentation of the trabecular meshwork, whereas it is coarse and patchy in pseudoexfoliation. Then you also have to look for iris changes like iris atrophy and iris whirling. It is seen in post-congestive glaucoma, iris whirling. Then you also have to look for the lens where you can get subluxation, dislocation, total cataract. All these can cause secondary glaucomas. And even you can get, if it is pseudophakia, vitreous blocking the pupillary area. That also you have to look for. Anterior chamber assessment, you know, all this is done by, first method is Van Herrick's grading. And this is the classical Van Herrick's grading, you all know that. And what are the other features? So you always have to do gonioscopy in all cases of glaucoma. And in gonioscopy, you can see that the first one is the open angle. You can see the all four structures, that is the root of the iris, scleral spur, trabecular meshwork and Schwalbe's line. This is a closed angle. Always look for corneal wedge. Why it is important? Because sometimes you may get pigmentation over the Schwalbe's line, which you may mistake for trabecular meshwork. So always you have to look for this corneal wedge, because this corneal wedge that meets at the Schwalbe's line. Now this is angle recession glaucoma, and the other one is, this is blood in Schlemm's canal, and this is neovascularization of the angle. And you should know how to differentiate between normal iris process and also peripheral anterior synechiae. Irises process are usually fine processes, whereas peripheral anterior synechiae are broad, and they extend to the scleral spur, this iris process, but this PAs can extend beyond the scleral spur, and they do not, iris processes do not obscure the angle structures, whereas PAs do obscure. Then now you can see this is angle recession, especially if the glaucoma is unilateral. Always think of a secondary cause. This is silicon oil blocking the angle chamber. Now always while drawing, you have to write the structure, posterior most structure which is seen, and always you try to put an arrow and write the structure which is seen after manipulative gonioscopy or indentation gonioscopy. That is the best method, rather than writing grades as grade 3 or 4 or 2 or like that. Now, optic disc evaluation, it's a very important one. You have to actually quantify the optic disc measurement, which you can easily do in a slit lamp examination. You reduce the size of the beam, both vertical and horizontal, and you can see a marking over the slit lamp, and you have to multiply by a multiplication factor according to the type of lens you use. Then one important factor while evaluating disc is the disc size. Always you have to think of the disc size, because in these two pictures you may think that the cup disc ratio is more in this, but actually the disc size is also more. So always think of the disc size before commenting the cup disc ratio. And these again you have, this is a small disc, this is again a small disc, but this is a large disc. This is DDLS score. Hope you all may be aware of that, because the problem is in DDLS you are measuring the rim width, whereas in cup disc ratio you are only measuring the cup disc value alone. So always you have to think, you should know what is this DDLS scoring. Now we will see some features of the optic disc. Here you can see the cup disc ratio is around 0.7. Here there is inferior thinning of the neuroretinal rim. So always you have to think of ISNT rule. Inferior rim is usually thicker than the other rim. So again here it is almost same. Inferior is not thick. So it is again pathological. Here it looks normal. Here you can see both the superior rim is more thinner than the inferior. It is almost, this picture almost it is glaucomatous optic atrophy. Now you have to look for peripapillary areas. You have beta zone which is closer to disc, and alpha zone is which is outside. Beta zone is significant of glaucoma, and it usually corresponds to the area of nerve fiber layer atrophy. And always you have to look for the nerve fiber layer defects. You can see it is better appreciated in red free. Here you can see a superior, here you can see both superior and inferior. And you have to always see the HFA findings also. Some clinical scenarios. Here is a 56-year-old female with normal intraocular pressure in right eye and slightly high intraocular pressure in left eye. Angles are open. Right eye, the cup disc ratio almost looks normal. Here you can see the HFA also looks normal. So it is almost normal in right eye. In left eye, you can see there is a superior thinning. So you expect a field defect in the inferior part. So there is an inferior arcuate scotoma. So always correlate. Here also you can see a scotoma in the infronasal part. So where do you expect the change in the disc? Supratemporal. Yes, so you have to look for the change supratemporally. Then again you can see the inferior neuroretinal rim is thin here, and you get a corresponding superior arcuate scotoma. And here you can see the disc looks almost normal, but here you can see the inferior neuroretinal rim is slightly thinner. And you can see the corresponding field defect in the superior part. Here again superior, both superior and inferior rim is thin, so you get bilateral or double arcuate scotomas. So again this is another patient with occasional complaints of occasional blurring of vision and slight pain in right eye. Van Her is grade 1, AT is almost normal, so you can see the angle. This is occludable angles. Do we need to do laser PI? Yes. Why? Because you are seeing peripheral anterior synechiae, and also in patients which who need frequent dilatations, if you get occludable angles, definitely you have to do laser PI. And this is another patient, again closed angles post PI. You can see there is slight inferior neuroretinal rim thinning here. Here both superior and inferior rim is thin. So what is the diagnosis? Primary narrow angle glaucoma. Why? Because there is optic nerve damage in this. Thank you. Now we would like to invite Dr. Babita for a discussion on orbit cases.